So at the end of the day, we need to focus on personalization, personalization, personalization. But it's not just a personalization of the tumor and the genes that are driving the tumor's behavior. It's a personalization with respect to host responses to the various therapies that we provide. So with the last remaining few slides, I want to talk about what we've learned from the oligometastatic studies that we've done and where we need to go. I think, again, using a number to decide whether a patient has oligometastatic disease is not an ideal choice, to put it mildly. I think if you look at this graph that I curved out very haphazardly in PowerPoint, you can understand the message, which is basically that at diagnosis, it may appear that you have oligometastatic disease, but once first-line therapy starts, your tumor burden systemically can go in many different directions. And just taking the initial snapshot in time to understand what is oligometastatic is really poor. We need to have probably a better biologic understanding of which patients will have microscopic or subclinical disease that may manifest more quickly versus those patients that have disease that may not manifest for a long time, for which local therapies may be helpful. You know, all our clinical trials to date have focused on being agnostic to systemic therapy, meaning we've permitted all regimens of FDA-approved regimens on the trials to be pragmatic about keeping these studies enrolling rapidly. But the good aspect is that, yes, we will be able to enroll more rapidly, and we are permitting and having a good understanding of how all standard of care systemic therapies may synergize with local therapy. The bad aspect about that is that by, we may dilute out the benefit that a specific systemic therapy may have with a local therapy. And then, again, if you only prioritize one systemic therapy in the clinical trial, it may give you an easier time to interpret the data. I've already talked about number 4, oligometastatic disease that started at diagnosis and stayed oligometastatic based on purely our numerical evaluations versus a person who may have developed oligometastatic disease by numbers after induction systemic therapy. I think those two patients represent different patient populations, and as much as possible, we need to be clean about which patients that we're really including in our clinical trials. Patients with target mutations are a very important group, of course, but their biology is really much different. For instance, they don't respond very well to immunotherapies in the second-line setting. And so, I think it behooves us to keep those patients separate in these oligometastatic trials as we go forward. This idea of metachronous versus synchronous metastatic disease, the idea meaning when you're diagnosed, if you have metastatic disease, that's synchronous metastatic disease at the same time, versus a patient that may have had stage 1, 2, or 3 disease, was treated with local and systemic therapy, and then maybe 5 years down the line developed a single metastasis. I think it's very important that we understand that that probably represents, again, 2 different biologic spectrums and that they need to be treated differently. I can go through, for number 7, over and over again, a list of how many different doses and fractionations of radiation we could theoretically use to optimize the synergy with immunotherapy and dealing with disease. But I think those basket or umbrella trials that I highlighted before may give us a little bit of insight. And ultimately, 8 is really what we're aiming for. We need to identify metastatic tumor or host tissue biomarkers that are predictive and prognostic of, number 1, durable responders to systemic therapies, such that we can be more convinced that a local treatment of a local site of disease may actually be beneficial if they're responding durably to systemic therapy at other sites of disease. And then again, it goes hand in hand. It's about the same thing. Those patients that truly have oligometastatic disease so that they can maximally benefit from local therapies. And so I think I have 2 minutes, future directions. I think we need a better understanding of trial eligibility, meaning we need to enrich for those patients who we think have oligometastatic disease. And I'm going to read what I underlined because I think it's very important. And it's something that we could do, for instance, rather than the number of lesions and a strict time to start local therapy, we theoretically could follow ctDNA levels, for instance, to determine disease burden that can potentiate the development of new sites of disease. And so, for instance, if that ctDNA level is low, we may want to treat all visible mets, no matter the number, if we can do so safely and obviously, because the likelihood is there may be quite a bit of time before there's more clinically apparent disease. If the ctDNA level is high, for instance, it may suggest that the disease we're seeing by imaging is the tip of the iceberg and we should lay off the local therapy. I think trial design is very important. There are new approaches called smart trials, for instance, that allow patients to go on study, and if they don't respond to a therapy, stay on study and get a different type of treatment. Those type of unique and innovative studies may help us do trials faster. I think real world data is very important. For instance, the UK, United Kingdom, made SBRT a standard treatment for oligometastatic disease, not based on a randomized phase 3 trial, but based on collection of data on a registry study. Could we do similar things in the US? I think it's possible. There's a lot of words on this, but I'm just going to say that we need better biologic markers of oligometastatic disease to avoid including patients with a lot of heterogeneity on these clinical trials. And we need to continue to work with our medical oncology colleagues to understand what the potential limits are of systemic therapy and to see how we can synergize with radiation, for instance. And my last slide is to say that ultimately, at the end of the day, for all our patients, we are personalizing therapy. We've done so for many different patients with many different tumor oncogenotypes. We need to do the same for patients with oligometastatic disease who could benefit from local therapy. And with that, I'll conclude